Thank you for coming to my TED Talk. My topic today is acute renal failure. My name is Elizabeth Velasquez, and I'm going to start with some interesting facts about kidneys. The functional unit of the kidney is called the nephron, and each kidney in the adult has approximately 800,000 to 1.3 million nephrons. Two kidneys filter 1,100 to 2,000 liters of blood per day, which equals the volume of a car. 800 milliliters to 2,000 milliliters of urine is produced by the average adult every day. And once every 4 minutes, the entire 5.6 liters of blood pass the kidney. Here's an illustration of the excretory system or urinary system. And here is the anatomy of the kidney and different components of it. Here is the functional unit of the kidney, the nephron. It's responsible for filtering and processing blood to form urine. Its main function is allowing water and small solutes such as electrolytes, glucose, and waste products to enter the renal tubule while retaining blood cells and large proteins. From this illustration, you can see that the kidney has numerous functions, including regulation of ions in blood, regulation of blood volume, regulation of blood pH, production of hormones, and also excretion of waste. Acute renal failure, most commonly referred to as acute kidney injury, is a sudden decline in kidney function that occurs over hours to days. So it results in the kidney's inability to adequately filter waste products, regulate electrolytes, and maintain fluid balance. Acute kidney injury is common in hospitalized patients, and it's associated with increased morbidity and mortality, especially when not recognized early. So the kidneys maintain homeostasis by filtering blood through the glomeruli and reabsorbing needed substances, as well as excreting waste through urine. In acute renal failure, this process becomes impaired, leading to decreased glomerular filtration rate. Acute kidney injury develops through three primary mechanisms: reduced renal perfusion, direct kidney damage, or urinary outflow obstruction. Regardless of the cause, the end result is impaired filtration, accumulation of nitrogenous wastes such as urea and creatinine, and electrolyte imbalances and fluid overload. At the cellular level, reduced oxygen delivery or toxic injury leads to tubular cell dysfunction and inflammation, and sometimes cell death. So this disrupts the sodium and water handling, causing oliguria or anuria in many patients, and if prolonged, these changes can progress to permanent kidney damage. The causes of acute renal failure are classically divided into three categories: pre-renal, intrinsic, and post-renal. So in pre-renal, acute kidney injury is caused by decreased blood flow to the kidneys without direct damage. So common causes include dehydration, hemorrhage, heart failure, sepsis, hypotension, and reduced perfusion lowers GFR. If not corrected, this may lead to intrinsic damage. So intrinsic acute kidney injury results from direct injury to the kidney tissue. Most common type is acute tubular necrosis, often caused by prolonged ischemia or exposure to nephrotoxic substances such as contrast dye, certain antibiotics, NSAIDs, or chemotherapy drugs. Other intrinsic causes include glomerulonephritis, acute interstitial nephritis, and vascular disorders. Post-renal acute kidney injury occurs due to obstruction of urine flow. Causes include kidney stones, enlarged prostate, tumors, or urethral strictures. The obstruction increases pressure within the kidneys, impairing filtration. Epidemiology: acute kidney injury is common, particularly in hospitalized and critically ill patients. It affects approximately 10 to 15% of hospitalized patients and up to 50% of patients in intensive care units. older individuals with diabetes, hypertension, or heart failure, or pre existing kidney disease are at higher risk. Acute kidney injury is associated with increased mortality, especially when severe or untreated. The pathophysiology of acute kidney injury varies by etiology, but ultimately it leads to decrease in the glomerular filtration rate. So, in pre-renal acute kidney injury, reduced blood flow lowers renal perfusion pressure, decreasing filtration, and if prolonged, this can progress to intrinsic injury. In intrinsic acute kidney injury, damages to the nephron, particularly the renal tubules, impairs filtration and reabsorption, leading to accumulation of waste products such as urea and creatinine. And in post-renal acute kidney injury, obstruction increases intratubular pressure, reducing glomerular filtration rate and causing backflow injury to the kidneys. So these mechanisms result in fluid overload, electrolyte imbalances, and metabolic acidosis. Some pertinent history questions to ask your patient regarding this. Key history questions focus on identifying reversible causes. So, recent vomiting, diarrhea, poor oral intake, or blood loss. Use of nephrotoxic medication, for example, NSAIDs, ACE inhibitors, contrast dye, or aminoglycosides. Symptoms of urinary obstruction, hesitancy, decreased stream or flank pain. Recent infections, sepsis, or hypotension. Chronic conditions such as diabetes, hypertension, or heart failure. And some expected physical exam findings include, actually they depend on the cause and severity of the acute kidney injury. They include signs of volume depletion, hypotension, tachycardia, dry mucous membranes, signs of fluid overload, peripheral edema, crackles, jugular venous distension, decreased urine output, oliguria, anuria, abdominal suprapubic distension, suggesting urinary retention. Some diagnostic tests and key laboratory findings. Diagnosis is based on changes in serum creatinine and urine output. So, rising serum creatinine and blood urea nitrogen (BUN) test is an indication. Electrolyte abnormalities, hyperkalemia, hyponatremia, metabolic acidosis. Urinalysis may show casts, protein, or blood depending on etiology. Fractional excretion of sodium, FeNA, helps distinguish pre-renal from intrinsic kidney injury and acute kidney injury, and renal ultrasound is used to assess obstruction. Some complications. So, if untreated, acute kidney injury can lead to life-threatening electrolyte disturbances, especially hyperkalemia, pulmonary edema, and heart failure. Uremic complications such as encephalopathy or pericarditis, progression to chronic disease, kidney disease, or end-stage renal disease, or increased mortality. So, some treatment and management. And the treatment and management focus on the underlying causes and preventing complications. For pre-renal treatment, treat the underlying problem, GI losses, attempt to reverse oliguria, fluid challenge, avoid if patient has signs, symptoms of fluid overload. There's also restore perfusion with IV fluids in pre-renal acute kidney injury, discontinue nephrotoxic agents, relieve obstruction in post-renal acute kidney injury, catheterization, manage electrolytes and acid-base imbalances. Dialysis may be required for severe or refractory cases. And conclusions. Acute renal failure is a common and potentially reversible condition if identified early. Understanding its cause, pathophysiology, and clinical presentation allows for timely intervention, prevention of complications, and improved patient outcomes. Early recognition and prompt management remain the cornerstone of care. Here are my references. Thank you. You have been an awesome audience.